are going to be joining us today, but in the interest of time, and we've got quite a lot that we'd like to get through today, I think we'll just get cracking. So thank you very much for taking the time to join us here today in our next iteration of the North West London Cancer webinar series. Today we'll be focusing on the DES contract for early cancer diagnosis, and within that will be a focus on cancer screening programs. So for those of you that don't know me, my name's Abhijit Gill. I'm a GP. I work in Hammersmith and Fulham, but I'm the cancer clinical director for RMP covering Northwest London. I'm lucky enough here to be joined by Baldeep. Baldeep, would you like to introduce yourself?
Thank you, Abs. Hi, I'm Baldeep. I'm a GP in Hammersmith and Fulham, and I'm also the Hammersmith and Fulham Cancer Lead for RM Partners.
Thanks, Baldeep. So we'll be co-chairing this series today. So just a couple of housekeeping rules. As always, I'm sure you're very used to this, but can we please just make sure that everyone's muted to avoid any background noise? Switch videos off where possible. We just want to save the bandwidth to make sure things go smoothly. And can we use the chat function as the main way of asking questions, and you can raise your hand as well if you'd like to as well. We're recording the webinar, and all slides and recording will be sent out via the training hubs and primary care comms team. We will hope to get all these things up on the RMP website as well. We're going through a bit of a change there, and like I said, please try and make this interactive, ask questions, make comments throughout, and we will welcome those challenges. At the end, we'll send out an evaluation link, so that's really helpful for us to make sure that we're doing all the right things and addressing your questions and needs. So please do fill that out so that we can use that to inform our next webinars. Brilliant. Can I have the next slide, please? So like I said, the aims of today really will be to clarify the requirements of the early cancer diagnosis DES. Interesting because we're coming to the end of this financial year, and I'm sure everyone's made significant progress with this already, but there are some iterations that have just been released on the 1st of March, a couple of days ago, about next year. So we'll spend a bit of time recapping about this year and thinking about the last bits and pieces that may need to be tied up, and then looking forward to next year and what are the new requirements and what changes are coming out. And we will look specifically at how we can use data and some suggestions about how to identify areas of focus and to improve the health outcomes for those individuals that are living with cancer or have a potential cancer diagnosis. We'll have a look at a couple of best practice examples to help support delivery and focus again, like I said, on screening and the national screening programs that are available and how we can best try and offer these to our patients. Here's the agenda, and as I said, we'll cover these things in detail. So quite a packed agenda, quite a lot to get through here today. So the first thing I want to do is actually introduce you to your Northwest London GP cancer leads at a borough level. So here's some faces. It's our lovely team here across covering every borough within Northwest London. We've got Lucy in Central and West, Baldeep and H&F, as you know, our other Lucy in Hounslow, Busher in Hillingdon, Lindsay in Ealing and Brent, and Meadle and Harrow. Can you remember these faces, please? Because they're already out there working with every practice, helping facilitate not only the requirements of the PCN DES, but also talking to you about important aspects in how we can help our patients in cancer care. So their emails are there. They're a point of contact. Please do raise any questions, issues, and support directly to Lucy, and obviously back to me as well as needed. So how will they be supporting you? Well, actually, what's often quite useful in feedback we tend to get is what is relevant to my practice, what is relevant to my PCN, can I see some data? And so we will help provide with relevant cancer data and also help you interpret that data to the needs of your PCN population. How can we create an action plan in order to improve the lives of those individuals that are living with cancer, and also improving cancer diagnosis and pathways based on your local data and local population. We'll make you're probably getting lots of comms locally from your cancer leads and providing updates not only about education events, but what's happening to changes in pathways, different resources that are out there, and basically a line of communication there for you. Bits about safety netting, I mean, we will cover that also today, and support again, as we said, for the QoF-QI and DES. Brilliant. Next slide, please. So I think to start with, what we'll do is we'll confirm the requirements of the 21-22. So we're coming to the end of this now, and let's just recap by having a look at the DES requirements and the QOF indicators. So what you will see is that while practices are expected to continue to maintain their cancer register and focus on the 2 cervical screening indicators, which will be measured for performance at the end of 21-22. The remaining QOF indicators relating to QI have been basically awarded in full, with the points relating to delivery of cancer care reviews, they've been reallocated to prescribing indicators. And you'll see that the DES is technically still in place, but the majority of the IF indicators have come as income protected. Now they will recommence from 22-23, and we will have a look at that moving forward. And there's a comment in the chat box that someone's not seeing the presentation. Baldeep, can you see the presentation?
I can see it.
So I'm sorry, that might be just a local thing. I hope that everybody else can. Can we go on to the next slide, please? Okay, so looking ahead, so we've talked a little bit about 21-22, and I'll go into that in a little bit more detail, but looking ahead at 22-23, we'll resume. Sorry, next slide, please. Thanks, Sophie. Can we go to slide 10? Okay, while that's coming up, what we know is looking ahead of 22-23, QOF will resume, and there will be no new additional indicators that will be added to QOF when that temporary income protection comes to an end in March of this year. Now, this is the DES requirements have been updated for 22-23, and early cancer diagnosis requirements have actually been streamlined and refocused. And actually, I think this is really helpful. Some of the feedback that we've often had about the DES is that it's sometimes slightly difficult to interpret. It's been quite broad and open to interpretation, but the requirements that have been set out for 22-23 are streamlined, they're focused, and it helps us actually understand what we need to deliver. There is a focus on the national diagnosis priorities and also a little bit about FIT, and we will talk about this later on and we'll break it down very simply. There's a new investment for IIF, the impact fund requirements, and that will also relate to FIT testing, and we'll come onto this in a little bit more detail. Right, okay, so QOF and the DES. Next slide, please. Often what tends to happen and the feedback we tend to see is that there is a overlap between the QOF and the DES. Now, this slide I can see is blank, but actually what we'll do is we'll make a reference to this later on and circulate this slide. And what we had here was the Cancer Research UK slide, which broke down the QOF QI 21-22 guidance and compared it to the DES. Now, what we had here, what you know, is within the QOF QI, we have to identify areas of improvement, which includes an assessment of screening uptake rates, the referral process and safety netting protocols, then create an improvement plan based upon the areas of improvement that you have in your specific area. And then use that to kind of follow up and implement the plan and have some GP network peer review meetings, which there should be a minimum of 2 GP network peer review meetings. This particular slide is blank. I know that. I'm sorry. I'm not sure what's happened there. But I know I'm just reading off this one particular slide. I'm hoping the next slide isn't. And then we compare it to the early cancer diagnosis DES for 21-22, where the points that were associated actually look quite similar. So next slide. Brilliant. All back. So I guess here the summary points are what are the similarities and what are the differences between the QI and the DES. And the similarities are that they're focusing on earlier cancer diagnosis and what we can do in primary care, and focusing on both on screening uptake and referral practices. The differences are QI is at a practice level, and the PCN spec is obviously at a scale, a larger scale, and there was no specific funding related there. Now, what we know is as we bring things together as a PCN, We can drive clinical leadership, we can coordinate and avoid duplication, and we can share learning, and we can have some discussion regarding all the different bits of variation within practice, and build on best practice as well. There will be variation not only that we've noticed locally at a PCN level, so practices within PCN may be doing things differently, even though we think we may not be, and so we can learn from each other, and we can make sure that things are streamlined. Thank you. Next slide, please. Baldeep, over to you.
Thank you. I'm going to walk you through the DES for early diagnosis and the 4 different components for it. So we'll start off with reviewing your referral practices for suspected cancers, including maximising the use of non-site specific pathways, working within a community of practice, and we'll go through all of this in detail, and also how actions to improve referral practices too, especially for those disadvantaged areas where early diagnosis, as we know, are quite low. The new arm for the DES is adopting and embedding the FIT, which we're going to talk about as well, and then the use of teledermatology for our skin cancer referrals, and then also prostate cancer as well, which is new. So we're going to talk about how we're going to implement a plan to try and improve proactive and opportunistic assessment of patients that could potentially have prostate cancer in targeted populations. And then I'm also going to go through how we contribute at a PCN practice level to locally for national screening programs, focusing on cervical and bowel cancer screening in particular. Next slide, please. Thank you. So reviewing your referral practices for suspected cancer and recurrent cancers. This is something that to look at within the practice. It's looking at your cancer referrals, looking at the quality of the referrals, and then also discussing them within a community of practice to share best practice and work on practice improvement plans as well. And then also thinking about maximising referrals to the rapid diagnostic centres which are popping up, and Abs will go through in more detail what these are and the type of patients that rapid diagnostic centres take. Next slide, please. So reviewing the quality of cancer referrals. So it's reviewing it against the NICE guidance, the NG12 criteria. And you can look at this, you can run searches at a practice level and look at each referral that has gone through and assessing each referral and seeing the appropriateness of it. You can also use the clinical decision support tools. And I know in some areas it's see the signs and some areas don't use a support tool. But you can also look at practice level data using the public health fingertips data and the NHS viewpoint. To look at what your diagnoses, cancer diagnoses are, the prominent diagnoses and the local presentation as well. And then also, as I said, maximising the use of the rapid diagnostic centres for non-site specific symptoms. And these are patients that tend not to fit into a traditional 2-week wait pathway, that you have some concerns that they may have an underlying cancer and actually they'll be seen quite rapidly. And it's doing all of this within a community of practice to identify and implement actions at a practice and a PCN level with an emphasis on inequality and areas that are disadvantaged and where patients are less likely to present to GPs and where our early diagnosis cancer rates are lower. Next slide, please. So we'll start off with the community of practice. So this is, as Abs mentioned, peer-to-peer learning events. So as part of the DES, the requirements are 2 peer learning events to take place within PCN level. And this is to look at your data, the trends of your data, and the diagnoses across the PCN, including delayed diagnoses. And this is a good opportunity to engage with the local partners and your patient participation group, the secondary care, the Cancer Alliance, your Cancer Borough leads, and commissioning health teams as well. So it's dedicated PCN time to really discuss the trends that you found and the data that you've looked at to identify particular areas in need and patients that are in need. It's also an opportunity to talk about the case study and what good learning you've picked up from it, and looking at delayed diagnoses and what you could do differently next time. Are there systems that you could put into place that could improve referral practices and quality of referrals? And then it's completing a reflecting template about this within your PCN. Engagement with patient participation groups is key, really, because I think that helps get you can talk about awareness of cancer symptoms, helping improve cancer screening numbers and encouraging people to come in for their screening. You can also invite your local trust colleagues as well. It's a good opportunity for that. And it helps establish good relationships within the network and within the cancer network to help improve your cancer screening numbers and also referrals. Next slide, please. So we put a checklist here for the community of practice. So it's engagement with the CCG and Cancer Alliance, and then engagement with your local GP borough leads, confirming a cancer lead at each practice as well to hold on to this piece of work and see it through, working with your local borough leads to develop a QI project, and we have some examples of these throughout. Collaborating as a network, as a PCN as well, and really focusing on those areas, as I've said a number of times, on those disadvantaged areas and those areas where patients don't tend to present as much in regards with cancer diagnoses and screening as well. And then looking at the local screening providers as well to see if we can invite them, or any projects that are going on around you that can help support you with the QI project. And engagement of your patient participation group to help with your improvement plan. Next slide, please. So an example of a QI action for a PCN, as we said, we've got two meetings. You have 2 meetings to fulfill the DES. Well, one suggestion is looking at your recent cancer diagnosis. You can run a search and look at your recent cancer diagnoses, look at if there's any delayed cancer presentations or emergency cancer presentations. Look at it as an SEA, identify it, work on what areas were of good practice that could be shared amongst your peers, or areas that could be improved on, and actually put in plans in place to help implement those as well. And then there's the RCGP toolkit, which helps you quite nicely with working through an SEA. And as I said, each practice should discuss their findings at the PCN meeting, and there should be 2 meetings. Next slide, please. Abs.
Thanks, Baldeep. So what I'm going to just go through now is a couple of the R&P initiatives for early diagnosis, which you may find helpful engaging with in order to kind of deliver on some of these issues that, and points that Baldeep has mentioned already. So I'm just going to go through a couple of bits and pieces. So within 2 boroughs in northwest London, so that's Hammersmith and Fulham and Hillingdon, we are lucky enough to be part of the national pilot for the Targeted Lung Health Checks programme. So the aims of this really is to diagnose lung cancer earlier. We know that lung cancer is difficult to diagnose and often will present at a later stage 3 and 4, knowing that later stage diagnosis confers poor prognosis. And so an identification of patients is happening at those at increased risk, aged between 55 and 74, that are ever smokers, so have a smoking history, current smokers or ex-smokers, and inviting them for a lung health check, and where eligible, they will have a low-dose CT of their thorax, and the purpose of that will, and so from Hillingdon, it's running out of a mobile unit. I think it's in a Tesco car park, and with Hammersmith and Fulham, it's through the Brompton, and so it's available for all practices that have signed up within those areas, and our borough leads are working closely with practices to get them to sign up there. I would certainly encourage that those individuals, and I know within H&F they're not completely signed up, but please do liaise with Baldeep and make sure that happens. It provides an incredible service to be able to try and diagnose lung cancer earlier in a way that we haven't done before within northwest London. Next slide, please. So this is some information really about the data that's coming out of the Lung Health Checks programme, about the activity that's happening. In Hillingdon, we're almost fully there, with 45 out of 46 practices signed up, and in H&F 21 out of 29, so a little way to go. And if there are any practices representation here on the call today, those that haven't signed up, please do, because patients are reaching out to us from the practices saying that they would like to be a part of this, but unfortunately due to IG rules we can't do that unless we've got sign up. So a little bit, so you can see the numbers here about patients that have been invited, health checks that have been done, which is more than the CT scan, and then the CTs themselves. And we're finding the outcomes from this. There have been lung cancers that have been diagnosed, there have been other cancers that have diagnosed, and there have been some incidental findings as well. What's great about this is that it's not extra work for the practice. If a cancer is diagnosed, that's automatically upgraded, obviously, into an MDT, be that lung or another cancer of a different primary. If an incidental lung nodule is found, it goes straight into the lung nodule pathway for interval scanning, etc., and that all happens without the need for any primary care input. And vast majority of any other incidental findings are dealt with, but there may be a little bit of feedback that comes back to the GP saying we've also found X, Y, and Z. And often, probably the most common incidental finding will be coronary calcification or something like that. Brilliant. Next slide, please. And this is a project that we ran in Hillingdon some time ago. Well, some time ago, it was about 6 months ago. We focused on potential missing first treatments in urology. Now, the reason that we did this was that we had data to suggest that there was a large disparity in first treatments within the population of Hillingdon. Now, what does that mean? So missing first treatments is a proxy for missed cancer diagnosis. We have the pandemic, and we've got data from before and kind of during the pandemic, just after, and where we are now. And we knew that looking at data trends of patients that have started their first cancer treatment, we significantly dropped off, knowing that therefore we were probably, well, we have been missing a number of urological cancers, and a lot of them were in Hillingdon. And what we were concerned about was how do we actually reach out to these patients? A lot of work was done through comms, a lot of work was done through patient-facing and GP comms. We all were aware about this and we spoke about this at length, but we tried to run this retrospective search within Hillingdon, and we engaged with some PCNs, which were, and I thank them very much here if they're here today, for working with us. It was an incredible piece of work, because at a time where GPs were incredibly busy, but managed to do some of this work. And we looked back at patients that were at higher risk, so smokers over a certain age threshold, and if they had come and called the practices asking for antibiotics with a suspected UTI but didn't have their urine dip done. So we were looking back to see if we'd missed any microscopic hematuria where they didn't have a UTI and they had dysuria and a raised white cell count, which fit the 2-week wait rule. Now, interestingly, despite actually there wasn't a huge number that came through each practice, which was great, so there wasn't a huge practice burden, but no, we didn't actually generate any cancers that were missed or diagnosed from that. So it was a useful thing to do because it felt important to go out there, but we didn't find any missed cancers at that stage. This issue was still there. We've done an audit across several thousand patients through the geography in North and South West London, called the staging audit. And within that, we know that urological cancers are still a bit of a problem. Next slide, please. I think this pretty much summarized what I've just said. Thank you. Next slide, please. RDCs, right. So I also lead on the Rapid Diagnostic Centre programme for the Cancer Alliance. Now, we've mentioned this already, and Baldeep mentioned this, and we know that this is featuring in our DARES. I'd very much like to talk about this in a bit of detail, so we've got a couple of slides here. So rapid diagnostic centres, it's specifically non-site specific RDCs are incredibly helpful and part of a national priority to help diagnose patients earlier. We have sites across North and South West London which are now live. The purpose of these RDCs will be for patients where you as GPs are worried about a patient that has cancer, but they do not fit an alternative 2-week wait pathway and are adults, so this is not for children. So you can see the referral criteria below, quite broad as you can see. Either there is a clinical suspicion of cancer or a radiological suspicion of cancer, but they don't meet alternative tumour-specific pathways. They must be well enough to come to clinic, so they're not sick enough to go to A&E, and aware that they may have cancer and they'll be sent to a suspected cancer clinic. Now, the common kind of things that come to an RDC would be, say, patients got a lot of weight loss, bony pain, lots of fatigue, the inflammatory markers are a bit off, they're anemic, all these kind of, we know, red flag symptoms, but don't package themselves well within a specific TWR. We know that this may not mean cancer, but there is a chance of cancer, and so these clinics are now being developed for this cohort of patients. Next slide, please. Now, we are able to refer to these clinics, and within the national plan, there needs to be 100% population coverage by 2024. Now, I'm pleased to say that we're going to be far ahead of that target. We have currently the above live sites. Now, relevant to Northwest London, we've got sites at Chelsea Westminster Trust, which are at Chelsea Westminster and West Middlesex. Baldeep works at West Mid, I work at the Chel West site, and we've got London Northwest as well, which is live. At the moment, we are available to the boroughs of Hammersmith and Fulham, West London, Hounslow, a couple of PCNs in Ealing, and Harrow. Very soon, we will be open to Brent. Very soon, we'll be open to the rest of Ealing, Central, and Hillingdon. Now, I know you're going to be on the call, and if you sit within those boroughs that are not yet covered, thinking, well, why not? And it's not fair. You're absolutely right, and we're working very hard to make sure that we have the right workforce in place, and it's really just simply a delay because of COVID, and we've had funding that's been approved some time ago, and these clinics are just about being set up. We won't have much more of a delay left here, and there will be a provision for 100% patient population coverage well ahead of the national target, which is in 2024. So how do you refer to an RDC? If you are within those patients, within where it is currently available, it will be on ERS. The referral forms, which I would highly encourage you to use, please do. It makes life much easier for us, and they are going to be integrated in System 1 or EMIS, and then you go on to ERS, 2-week wait referral, drop down to non-site specific symptoms, and it will come up. If it doesn't, if there's a problem, you must tell me, and I'll put my email in the chat box as always at the end. Good. Next slide, please. Right. There may be lots of questions about RDCs, but about it before I hand over to you, we are going to do a RDC specific webinar in a month or so's time. So we'll talk about all the different things and all the different data. There's a lot of information there. But this, I think we've got a lot here to talk about with the DES, etc. So I'll hand over to Baldeep.
Thanks, Abs. So moving on, we're going to talk about safety netting, which is a component of the DES as well, and safety netting our patients for suspected cancer or suspected cancer referrals as well. So it's ensuring that we have a good safety netting process in place. And it's not just for the 2-week wait referrals, it's also for patients that are presenting with symptoms that do have a serious disease, but you're not sure whether they have a cancer or not, and you've sent them off for investigations, whether it's whether it's open access diagnostics or a FIT. So it's having a robust process in place within the surgery, within your PCN, that works, and it helps track patients, put patients on a list, track patients, and ensure that patients are either seen, or if they're not seen, or they're DNA'd, to ensure why they've DNA'd, and then checking all of that in a timely fashion. It's also ensuring that your diagnostic results are checked in a timely fashion and acted upon as well. And this safety netting includes, it's a wide number of actions. I think each practice runs a safety netting process in a different way. Some practices use the CBIS Science integrated tool for safety netting as well. But I think as long as you can produce a safety netting policy that's IT based and that has a process in place, I think it's a good sign. Next slide, please. Here's a safety netting checklist that you might want to take away and have a look at, because it's quite helpful, really. It's, as I said, it should be a robust IT system. So it's not just for patients that are on for suspected cancer pathways, but patients that you've sent for urgent diagnostics as well. And that includes a FIT too, because if you're doing a FIT test, you're suspecting colorectal cancer. So again, that fits in with your diagnostics too. Following up patients that haven't been referred, but you think that there may be a serious disease going on there. And also patients that have been referred on a 2-week wait pathway but have been downgraded. So that when secondary care have downgraded the referral, ensuring that that's followed up too. As I said, mentioned earlier, making sure that bloods and diagnostics are seen and acted upon quickly. We have lots of patient information leaflets there, and we have them in different languages too. And this is for patients that have been referred to a suspected 2-week wait pathway, and I'll talk about signposting in a moment. I mentioned a cancer decision support tool, so CBIS Science has safety netting process in place, and I'm aware that a lot of practices use that too. Having a clinical and a non-clinical lead champion in the practice to monitor the safety netting process, so you've got fail-safe processes in place, and should be able to produce a copy of it, of your policy too. And the reason why I've put CQC in there is because this is the one thing that CQC do actually scrutinise and look at a granular level to make sure that processes are in place. Next slide, please. Here we've included a few resources to help you with safety netting. It's the Macmillan safety netting top tips, there's the toolkit there, and then there is guidance for GPs and GP practices from Cancer Research UK as well. And there's also a SNOMED code for safety netting. Next slide, please. So signposting patients. So quite often, as I've said, I run a rapid diagnostic centre as well here at West Middlesex, and quite often we'll get patients that come in and they're not sure why they've been referred, or they're not sure why they've been referred to a cancer clinic as well. So I think ensuring that patients understand that they're being referred for urgent investigations when you are triggering a 2-week wait referral, and ensuring that they're available, letting them know that they need to be available for the next 2 weeks for their appointment, and that they're going to a clinic where cancer is being ruled out is quite key, because it helps with patients actually attending their appointments and just gives them a little bit more information, and it also helps with their pathway and their experience as well from what we've seen. So there's the 2-week wait patient information leaflets that you can find, and they're in different languages and they can be easily sent out via AccuRx. Signposting for vulnerable patients as well. Have a look in social prescribers, and link workers are key for this as well. And Macmillan and Cancer Research also have resources available for you to tap into. Next slide, please. Abs.
Thanks, Baldeep. So looking ahead for the 22-23 DES, there are a couple of new points here, and that's to adopt and embed the requesting of fit tests for suspected colorectal cancer, and the use of telederm where it is available to support skin cancer referrals. So within the fit, we've got the IIF indicator, which we've taken a screenshot of there, and that's really going to be a measurement of the percentage of lower GI 2-week wait referrals that you've done, accompanied with a fit test, and with the result, which has been recorded either 7 days leading up to the referral or 14 days after the referral. Next slide, please. So fit tests are very important, and we talked a little bit about this when we had our last webinar for cancer, and we had Al Myers and Bushra here talking about lower GI cancers. And a big part of the national spec here and the move here is to make sure that we help streamline this pathway by doing a fit test. We all know about fit tests. They're available within our surgeries, and they're an incredibly helpful tool in order to streamline the patient pathway and also help risk assess within secondary care for the correct investigation where there is a suspected colorectal cancer. Now, there are a couple of scenarios which we know, which is reflected on the TWR form, where a fit test isn't necessary. So that's a rectal or anal mass or anal ulceration. But otherwise, we should be doing a fit test. Now, according to the form, and we can see here that those individuals with a fit of 10 or more, they'll be ones where you would be worried about a colorectal cancer and refer on to a lower GI pathway. And interestingly, we've done some work here, knowing that there's been some feedback that there may not be enough kits at times within the last year or so, and we've troubleshooted this locally. Our pathology labs across Northwest London have reassured us that there's not a lack of fit testing kits. Please, can you all take an action to think about who in your practice orders those kits, and what is your monitoring system for when things run a little bit low? And it's always advisable to order a little bit more, and there is a threshold to be able to order this, but that can be increased at a practice level if you find that you are going through a bit more and you're worried about it dropping off. So please don't look at the supply of a fit testing kit as a limiting factor in patient care to refer down a TWR, because we can always increase this. And if there are any concerns about how do you liaise with Northwest London Pathology, can you please go to your borough cancer leads. So the importance of a fit test is when that is received by the straight to test nurse within secondary care, is that they'll be able to triage quickly and in an appropriate way for the right tests investigations. Next slide, please. So what we've done is we've had a look at a couple of our trusts within Northwest London and help break things down to just gain a little bit of understanding. And so this information was an audit done, actually, it was a little bit of time ago, and it looked at the first 50 patients that were triaged to an outpatient appointment rather than going straight to colonoscopy or CTVC. And that was done at London Northwest in April last year. And if you break down the reason that they were triaged to an outpatient appointment, there are lots of things here and lots of reasons why they do that, but things that we can help improve on for our patient pathways and primary care. Now, fit less than 10 is one and no fit is the other. Now, I'd say fit less than 10, if we're still worried about colorectal cancer, then yes, absolutely, you can still refer those patients, but no fit is something that we can certainly avoid, and it's being made as part of our DES moving forward, DES contract. So it would be incredibly helpful to focus in on that. Another thing that we found was quite interesting, and part of, I think that's on the next slide. So this is something, Baldeep, you did within Imperial, and we had a look at referrals that were done without a fit test and those with a fit less than 10, looking at kind of the same stuff. But the key, something I found quite interesting, is that some people, some practices were referring patients with having requested fit, but by the time they got to that triage point with the nurse, the result hadn't come back yet. And so and that came back while they were on the PTL sometime later. Trusts are monitored and have to abide by what we call the fast diagnosis standard, which is the FDS, and within 28 days they need to give the patient a diagnosis of cancer or not, and therefore there is a pressure to be able to get on with tests. Now, so the value of the fit, we've all agreed, is in the triage of what is appropriate type of investigation. So although we've done the fit and we've sent the referral, if the result isn't there yet in time for that initial triage consultation, it may not be utilised. So I think what we should be saying to ourselves as primary care is, let's do the fit test and let's use the result to inform referral onwards. And even if it's less than 10 and we're worried, we'll send it on. But then at least the secondary care trust and the nurse there, the specialist nurse, can see that it's less than 10. If it's above, absolutely, it will help to direct whether this patient goes for a CTVC or a colonoscopy or an OPA first. But we must do the test, and that will fit in very nicely with our DES contractual requirements. Next slide, please. Baldeep.
So this is the third new portion of the DES, and this is the streamline area of it. It's looking at prostate cancer, and I think, as Abs mentioned, there was a big drop in prostate cancer diagnoses and treatment started during the pandemic. But it's really slow to recover, and it hasn't recovered, and it's still significantly low. So this has been included in the DES now. So we're looking at prostate cancer, and we need to develop and implement a plan. This is at practice level to increase proactive and opportunistic assessment of patients for possible but potential cancer diagnoses for prostate cancer. Now, March marks the prostate cancer campaign, and I think the figures speak for themselves. It's more common in men over 50. If there's a family history, there's also a risk there, and also in the Black population as well. And next slide, please. So it's having this in mind as well, actually, and I'm glad, and it's been brought to the forefront of the DES as well. It's ensuring that we have an awareness of the risk factors, so the ethnicity, but also the family history component as well. So maybe running searches, targeting that population, bringing them in for an assessment. We know men are less likely to access primary care or medical help. So again, it's a population that probably needs to be worked on and targeted a bit more. As I said, March is the Prostate Cancer Awareness Month, and there are a couple of resources here. There's Prostate Cancer UK have released a 30-second risk checker as well, which is something that your patients can go through. And also there's a film that's been released. Are we playing the film?
We're going to try and share it.
Which is quite powerful and impactful for the Black community to try and encourage patients to come in for an assessment.
So, Sophie, can you come off mute?
Can you?
It was playing, we couldn't hear it.
Apologies, could you hear that? Okay. Yeah, I'm not sure if it's going to be able to play the sound. So, Stevie, are you able to share? Nope.
Embarrassed. Too embarrassed to speak to a loved one. Too embarrassed to speak to your doctor.
Too embarrassed. When in our lifetime, 1 in 4 black men will be diagnosed with prostate cancer. 1 in 12 black men will die from prostate cancer.
Let me repeat that. 1 in 4 black men will be diagnosed with prostate cancer. 1 in 12 black men will die from prostate cancer disease.
1 in 12. That could be your dad, even your older brother, uncle, or grandfather.
You need to make sure they are not embarrassed to speak to you or their doctor about it.
Hey, Dad, have you had your prostate checked out? See? How hard is that? It's easy. Just start the conversation.
Prostate cancer is survivable if caught and treated early enough.
Don't let embarrassment stop you having this important conversation.
You may save someone's life.
Not just your own.
So that's quite an impactful film, I think. And I think it is going to raise a few questions in terms of PSAs and assessments. But I think from a DES perspective, it's looking at the population that are higher at risk and if you can, inviting them in for an assessment, going through the signs. Is a PSA indicated? Next slide. 42, please. Thank you. So the fourth part is contributing at a local level to the national cancer screening programmes. And we've got the three. We've got the bowel screening, the cervical screening, and the breast screening. So I'm going to go through each of those for you, and Abs is going to go through figures for you for North West London as well. So part of the requirement is contributing to improving local uptake, but improving local uptake with certain populations that are difficult to capture, or DNA appointments, populations that just struggle with screening, but also looking at those areas, and are there any other implementations, and are there social prescribers that we can help with targeting certain populations to increase screening within those areas. Looking at non-responders to invitations as well. And there are a few things we can do at a practice level that can help with promoting and improving screening throughout the practice in the PCNs. We've put on there that patients in deprived areas, with learning disabilities, physical disabilities as well, the Black and ethnic minority populations, again, less likely to respond to screening. So again, it's finding those areas and then maybe coming up with some kind of implementation plan to help improve. Next slide, please. So the National Bowel Screening Cancer Programme, it's a FIT test sent to home, offered to men and women ages 60 to 74, and this is soon to be, the age is soon to be reduced. If we normally get an indicator to say whether our patients have responded or not, and an opportunistic opportunity for when we do get non-responders is that we can actually send a text out by AccuRx with the screening helpline number, just to encourage patients to call the number to obtain the FIT test, because we know that for every positive FIT comes through, there's an 8 to 10% chance of that patient having the bowel cancer. So it's trying to encourage patients participating in the screening. Next slide, please.
Thanks, Baldeep. So this is just a little bit about the data across Northwest London, and as you can see, so specifically on bowel screening and looking at the coverage for the screening population aged 60 to 74, slightly outdated, as you can see, from March last year, but it's kind of the most up to date that we have at the moment. If you look down, this is coming from, oh, it went away. What happened there? Could we get those up again, please, Sophie? Thanks. Yeah, perfect. Thank you. So if we look down, we can see all the different boroughs that have been broken down. This has been lifted from the RMP screening dashboard, which our borough leads will help engage our PCNs with. And what we can do is not only by borough, but break it down from PCN and then also practice level. Now, the national kind of what we call threshold for bowel screening performance is 60%. We can see that as of March 21, Harrow, Hillingdon, and Hounslow were just above that, and the others were a bit below. I guess I want to draw your attention a little bit to a couple of these columns here. Now, after borough, we've got bowel screening performance percentage, and then 1, 2, 3, 4. Afterwards, we've got max screening performance and minimum screening performance at a practice level. And what you can see, based on that, within each borough, there is huge variation. So you may see that certain practices are doing very well and other practices are not. Now, what's important in our aims to reduce inequalities across Northwest London and also locally within each boroughs, we must try and focus on reduction in screening variation. And so our borough leads will be coming out to our practices which may have some difficulties engaging their patient population and trying to suggest ways in order to help with this. So please do link in with them. Next slide, please.
Sure. So I touched on some suggestive actions to try and improve the screening uptake. And I talked about proactively sending text messages to patients as soon as you become aware that you've got a patient that's not responded. And again, simple text with the bowel screening number on there to be able to get the kit can often help. You can run searches as well to find your small numbers. So those patients that are exiting bowel screening that haven't responded to their final screen, again, the numbers are often quite small, so they're a good population to target too. GP endorsed letters seem to work really well as well. So again, we've got some examples of there that you can send out, especially from Cancer Research UK, and customising that approach to patients with learning difficulties. And then also, I'm just going to talk to you about community links, which is another initiative that our partners are using to help with increasing our bowel screening numbers.
Thanks, Baldeep.
Next slide.
That's on the next slide. Yeah, thank you.
Oh no, sorry, it's me. Sorry. So this is a worked example of an improvement project looking at those final numbers, those last, the older ages. The exiting group, I should say, that would not automatically receive any invitation because they missed their last bowel screening, so they wouldn't then be invited. So New Malden and Worcester Park looked at this in depth and came up with an improvement plan to work on this. They created a list of patients. Each patient was contacted as to why they didn't complete their screening and would they like to. They were then helped with obtaining a kit from the screening hub, and then the plan was to re-audit to see the impact of the exercise. They met with their PCN cancer leads, explained that it would give the practice an audit cycle and appraisal so it fits in nicely and fulfills the DES for early diagnosis. So each practice ran a search for their patients to identify a dedicated admin team to make the calls, and it was started in April and it was going to be re-audited in July. And they were hoping to improve their bowel screening rates for that patient cohort and improving staff awareness as well, because I think this is quite a good one for the admin staff to become aware with talking about screening and encouraging screening and improving it from that perspective. And it also supports the PCN DES as well. Next slide, please.
Thanks, Baldeep. So something that would be really easy to engage with, which will help the screening part of the DES for bowel screening would be to be signing up to the Community Links project. Now, this is an RMP commission project across all boroughs within northwest London. As you can see, what this project does is that we've got a company called Community Links, and they will call patients that are approaching their 60th birthday, and this is what we call the rising population, so coming into the bowel screening program, and encourage them to take part. What we know is that if you capture patients at the beginning as they're entering a screening program and explain to them the benefits of doing so, they're far more likely to engage at that stage, but also throughout the remainder of their invitations between the ages of 60 and 74. So as you can see, we've got a breakdown of all the boroughs. We've had great engagement across northwest London, and we're working on a little bit in Harrow. And those of you that haven't signed up, please do. It's something very easy, and it will work very well to fulfill the DES requirement. Now, what does it mean from a practice point of view? All it means is providing the patient, doing a quick search, providing the patients that are approaching their 60th birthday, and then Community Links do everything else. So you don't have to do anything at all, and ties in quite nicely with what we have to do, but it's done for you, which is brilliant. And so as you remember back when we talked about screening, there are two parts of this. There are those that are non-responders, which don't come in here, but these are the ones that are coming into the screening program. So it does fulfill that particular part. So since May, as of last year, a significant number of patients in northwest London approaching their 60th birthday have been contacted. And of those that they managed to speak to, which were just over 9,000, 85% of them wanted to participate in the bowel screening program, which is great. Next slide, please.
This is the National Cervical Cancer Screening Programme. It's just a reminder of what it is and who it's offered to. So it's offered to women aged 25 to 49 every 3 years, and to women 50 to 64 every 5 years as well. And they can contact you to book an appointment. It's just a reminder to let you know that NHS England are also proactively texting non-responders and patients that haven't actually made an appointment for their first initial screening and their final screening. Practices, again, we talked about proactively contacting patients, non-responders who have previously been invited, or older women who are about to complete their final screening as well. So again, searches can be run, and we can encourage patients from that perspective to be able to come in, book an appointment, and have their screening done as well. Next slide, please.
So look a little bit on the data. So we've broken it down into the coverage of 25 to 49-year-olds, and the next slide will be the remainder of the screening population. What you can see here is the national target is slightly different from bowel screening. It's at 80%, and across geography, not only do we struggle a little bit with cervical screening performance, but also there is variation, as I pointed out, with the bowel screening program. And although if the one thing I didn't highlight within the data, and we will share these slides, the bowel screening program actually had improved compared to the 1920 baseline. However, we've dropped off slightly with cervical screening, which is the final column of this slide. So, quite clearly it's an area that we need to focus on, and quite clearly it's something that is a national priority and it's brought into the DES, but it also is very applicable to us at a local level, and will make a huge difference to our patients. The next slide actually echoes something very similar for the 50 to 64-year-olds, doing slightly better, which means that actually a slightly easier kind of patient population we know that to engage with and explain the importance of a smear. But again, the variation is there, and the difference in performance to the 1920 baseline is there as well. You may have heard about changes that have happened in Wales, for example, where the 25 to 49-year-olds have gone to a 5-year screening program. Currently, we're still on a 3-year for that individuals. And you may have heard on the radio a couple of days ago about those that are HPV vaccinated may be moving to a single smear. we don't have firm plans for this right now, and for the next year that is coming up for 22-23, please do look at these figures and look at what we have done and work with your borough leads to focus on your DES. And self-sampling is something that is coming in for cervical smears, and as soon as that comes in within the next few years or so, I'm sure that will be an absolute game changer for cervical screening.
So there's some suggestive actions here of what we can do, again, at a practice level or a PCN level to help encourage those numbers and encourage those women to come in for their smears. We've got the Joe's Trust training, which has gone down really well, and it seems to be pretty booked at the moment for non-clinical staff. We've also got the cervical cancer screening campaign, which is running from February for 10 weeks as well. We've got a number of leaflets. One thing to keep in mind as well, again with cervical and bowel screening too, is our out-of-hospital SNI templates, our LD patients and the QOF review. This is, again, we can ensure that the screening is up to date, and if not, point them in the right direction for that. Customising the approach as well, so you're not making sure that we're not causing variability here, and that we're actually, it's across the board, and we're not increasing issues with access and barriers to access as well. So we have a really good, we're going to send this out to practices too. This is a leaflet that was generated, and it looks at rape and sexual assault in London and then screening with regards to that as well. So it's really good information for patients and clinicians too. And then there's a number of screening initiatives across West London. Next slide, please. So there's the extended access cervical screening hubs, which you may have heard of across North West London. This is an RM Partners Cancer Alliance supporting PCNs to deliver out of hours cervical screening, so that it helps reduce inequalities and variations, so women can have their smears done in the morning, at the weekends, in the evenings. And we've got a number of participating boroughs in that. So as you can see, we've had, between September and December, we've had a good number of clinics and a good uptake of appointments as well. So it has got a good degree of utilisation. And you can see that Hillingdon, there's a couple of PCNs in Hillingdon, in Chiswick, and then in Hammersmith and Fulham too. And this really helps women allow access screening at times that are appropriate for them, which again helps reduce the inequalities. So the National Breast Cancer Screening Programme, again, this is just a reminder, this is offered to women at the age of 50 to 71 every 3 years. It's still in recovery due to COVID, and the projected recovery is for March 2022, which is now. Our partners are providing funding for screening services, commission community links to call patients, and this will be at the 6 weeks non-response stage, and this is focusing on areas where traditionally you get low uptake as well. What can we do at a practice level for this? So we often get the letters to say that women haven't responded to screening. I think proactively what we can do is, again, send out a text message to say, oh, I see you haven't responded to your breast screening. Here's the link to book in your breast screening with the booking details. Again, it's an easy QI project, and it's an easy way to try and improve those numbers and encourage women to attend screening as well. Next slide, please. So finally, we have the DES checklist. So this is finally to cover the whole DES for you. So completed inequalities and inequality self-assessment. So who are your targeted populations? Have you got a learning needs analysis? That's your SEA. Have you run local searches and come up with QI projects within your PCN? Have you met the safety netting requirements, and just ensure patients are given up-to-date details and ensure that they know what they're going for appointments and the 2-week wait? Have you looked at your screening data? And what is your quality improvement plan to improve screening uptake? Again, you can link in with your borough leads to help you with this, because we have the data available and we can really help support you through this. And then your peer-to-peer learning events as well, where a lot of best practice is often shared. Thank you. Next slide, please.
Thanks, Baldeep. So what we'll do is just run through a couple of resources to finish off. So in addition to kind of what we talked about, there are a few different learning points, and have a look at these in your own time. There is information from Cancer Research UK, and a lot of you may remember the the NCDA, which we engaged with, feels like ages ago, but pre-pandemic, and that had a look at kind of our processes with auditing cancer diagnosis internally. And the apart from CI UK, we've got the RCGP toolkits, which are really helpful, and the Macmillan Early Diagnosis Toolkit and SCA Toolkit as well. So I've used those myself, and I think they're incredibly helpful. PHE fingertips is also helpful. Again, data is a little bit old, and that's probably a limiting factor there, but it helps also break things down to now a PCN level as well, when it comes to national screening programs. And so take your time, have a look through all these bits and pieces, and work with your borough leads as well when they come and engage with with our PCNs to help fulfill a couple of these requirements. Next slide. So just quickly to touch on the education opportunities, we've RMP's commissioned a cancer education program across a couple of years, and this is delivered by Red Whale. Now, you should have all had invites coming in through this, and it started back in the 30th of November and been incredibly well received. We've had a huge number of clinicians sign up, not only GPs, but also pharmacists, GPNs, social prescribers, and all allied healthcare professionals. And it's not only about focusing on early diagnosis of cancer, but also supporting patients with long-term conditions as well, and obviously with the focus on cancer. So have a look. If you haven't signed up, you still can access and register. There's a link there, and enter the discount code. Otherwise, you'll end up spending a few £100s, and that makes it absolutely free. There are a series of virtual and face-to-face events. Face-to-face events will be coming soon. Baldeep touched on cervical cancer prevention training, which is delivered by Joe's Trust, and this is incredibly helpful for GP practice staff. And not only do they offer training for clinical staff, but also non-clinical GP practice staff is helpful through this link, and that may be reception admin staff as well to help increase awareness. And then the next slide, sorry, I was getting ahead of myself. So there are a couple of other bits and pieces here that you can have a look through. Will be equitable care for LGBT+ patients in cancer screening, and an early diagnosis webinar. There is a link there. Live through this, and some dates and booking instructions will follow through comms, and motivational interviewing for cancer workforce as well, which are things delivered by Health Dialogues. The webinars that we've done so far, I think we've talked about lung, heme, lower GI, and today we're here talking about PC and DES. And looking forward, we've got personalised cancer care, where we will be joined by the personalised care cancer representatives at RMP to talk through about personalised care and what opportunities there are out there. And that will kind of focus a little bit also on cancer care reviews to an extent, which is part of a QOF indicator, which we've had for a very long time and we're quite used to. We talked a bit about RDCs today, but we've got a dedicated hour and a bit for it in May, and by that time I should certainly anticipate that we'll have much better population coverage within Northwest London. So please do come and join us on those meetings. I'm very thankful for everyone to be joining here today and sharing, learning about patients that are living with cancer and improving the diagnosis of patients in cancer within our geography. So today, I think we've hammered you with a lot of information, myself and Baldeep, and thank you, Baldeep, for joining me today. It's been brilliant. I know we've had a couple of our borough leads on the call, so I might just get them to just show their faces and give us a wave. Lindsay, I know, was here but went. I think we've got Lucy Doherty and Lucy Hollingworth here, unless you've had to go. Are you here?
I'm here.
Lucy, would you like to say hello?
Yeah, hi everybody. I'm Lucy. I am a GP and I'm the RMP cancer lead for Central and West London boroughs. So it's nice to meet you all. And if there's any queries or problems or good things that are coming out of Central and West, then let me know. I think most of the practices will have my email address, or certainly should have. So please feel free to contact me directly if you need anything.
Thank you, Lucy. Lucy Doherty, are you here? the patient. Might be okay. Don't worry. We've in that first initial slide, I had the email addresses. So when we circulate these slides, please have a look at the start and engage with your local borough leads. We talked about the DES. We talked about the QOF QI. We talked about the changes. We've talked about the QOF indicators. We've given you some data. We've given you examples. We've talked about the focus on screening and screening variation. We've talked about RDACs. We've talked about FIT. We've talked about prostate cancer. We've gone through a lot, and I know that it will take some time to digest. So maybe have a refresher, engage with your borough leads, and please join us next time for personalised care. And please fill out the feedback survey. And I think Sophie's already put the link in the chat box, so please do that before you go, because I know what I'm like. If I go without doing it, I'll never do it. So please do that. Baldeep, anything else you'd like to add at this stage?
No, just for Hammersmith and Fulham, the last few practices that are waiting to sign up for the targeted lung health checks, please email me, but you will probably hear from me as well. So let's do it, because the campaign is out. We've got lots of patients that are asking to sign up for it, and we can't because some practices haven't signed up. So anyone from Hammersmith and Fulham, it's just that final push. Let's get them on.
Thanks, Buddy. That's amazing. Great. So we're 8 minutes early, and we'll give 8 minutes back to everyone. Thanks so much. This will all be uploaded and circulated. Please do the feedback survey, and see you next time.
Thanks, Abs. Thank you, everyone.